Editor-in-Chief of Journal of Midlife Health, which is a properly PubMed index journal, and Madam has revolutionized the journal so much that everyone, we are getting record number of articles from abroad, not only from India. And she has got and she's editor of 19th edition of source textbook of gynae. All of us have read textbook of gynae, source textbook, so she's editor of that. It's a great achievement. I'm really proud of you, madam.
It's so nice to
and she has got Korean award, lot of other books and editor. So I think without wasting time, let's start your lecture, madam.
Thank you, sir, for consenting to be chairperson for this session.
My pleasure, honor, madam. Thank you.
So today I have to speak on surgical management of endometriosis and its reproductive outcomes. So we know that endometriosis is an enigmatic disease, and so much we have to learn and know about endometriosis. So we'll focus on before IVF show it's causing, we are not able to retrieve the egg for access. Ovary is not accessible. So this is a case of grade 3 endometriosis. This endometrioma is totally adherent to the pouch of Douglas. So if we are in the right plane, there will be no bleeding. As soon as we encounter bleeding, we should think that we might be in the wrong plane. These tissues better lift the ovary, and slowly we can go. Patience is very much important. First of all, we have to mobilize the ureter also. So we have to sweep the ureter. As you can see, the ureter is moving. We have to, laparoscopic surgeries give very good view of ureter also. We have to sweep and sweep the peritoneum laterally. As you can see here, the peritoneum also becomes puckered. So the first step in endometrioma surgery is we have to mobilize the sigmoid colon, and then slowly with deliberate, just open these bipolar scissors, we can remove the adhesions. And many times it happens that while we are removing the adhesions, the point of entry of endometrioma, it ruptures and the endometrioma fluid is released. So copious irrigation should be done so that post-operatively there are no adhesions. So patient safety is very much important. Never do endometriosis surgery in a haste. So proper pre-operative counseling, do your own scan, look for pre-operatively whether the sliding sign is positive or not, so we can have an idea. Our brain, what the eyes can see, what the brain knows. So a proper knowledge is very much required. So what about the second look dilemma? These are the intraoperative measures we can adopt to reduce the incidence of adhesions. So there are still many controversies and unanswered questions about endometriosis. That is, according to the AICOG 2022 guidelines, there is no benefit of treating asymptomatic superficial endometriosis, which is found incidentally during the infertility workup. But if the patient is having age more than 35, the ovarian reserve is less, AMH is less, then we can operate these patients. Or if the patient is having bilateral endometriomas. And we also need to know that whether the location of endometriosis of the superficial lesion, it affects the fertility outcomes differently. And the cost effectiveness of whether we go for surgery first or immediately we go for ART. So that counseling has to be done. For DIE, complete excision of this rectovaginal septum, uterosacral, and shaving and all should be done. So there are no comparative studies which evaluate the spontaneous conception rate after surgery for an endometrioma or deep endometriosis compared to no surgical intervention. That is, whether we don't know whether deep endometriosis, curing it will improve our fertility outcome. And it is well known that endometriosis patients in ART also, the oocytes quality is hampered, the number of oocytes retrieved are also less. So as already stated, that asymptomatic women who are more than 35 years, whose ovarian reserve is less, or those who already have undergone ovarian surgery or bilateral endometrioma. So we can directly advise them for IVF, because surgery can further compromise their ovarian function and delay the start of treatment. But for highly symptomatic women and those whose intact ovarian reserve is good, unilateral, and endometrioma size more than 4 cm, we should operate them surgically. So according to the AICOG guidelines, in randomized trial, deep excision of endometriosis doesn't improve the reproductive outcome. It just provides a symptomatic benefit. And a word about fertility preservation, you should tell the patient beforehand. So, surgical excision of superficial endometriosis is an effective first-line therapeutic strategy. It provides diagnostic certainty and also improves the outcome. So, surgical technique does matter. It is a comprehensive plan. It's not an individualized fertility plan. It's not performed in isolation. So, patient should have a good realistic expectations. So try to preserve everything, each nerve, every blood vessel. It's our duty to preserve each healthy tissue. And before proper preoperative mapping is required, meticulous surgical planning, that is very much required. So take home message is see and treat laparoscopy is valid for minimal to mild endometriosis with infertility. There should be a complete resection and to improve the pelvic environment for conception. And post-surgical window, the timing is crucial. And long-term, we should think about her AMH and reproductive outcomes. Make it count. There are certain future directions that which biomarkers can benefit most from surgery. Long-term cohort studies are needed. So thank you for your patience here.
Fertility.
Yes, sir. 4 cm according to the AICOG guidelines. More than 4 cm.
More than 4 cm. And should we, like after treating, should we go for IVF straight away or we wait? You did say that 6 to 12 months. Yeah. Will that age will be the factor in that?
Sir, age is also important. If the patient is more
like you have done laparoscopy treatment, then she should straightway go for pregnancy. That we know. But should she go for IVF or we should wait for 6 months to 1 year by ovulation-inducing drugs or?
Sir, according to the guidelines, we should utilize for the 6 months for IUI and.
Unless she's more than 34, 35 years, I think. She's too close to the 35-year of age. So that is very, very important. And any question from the house? Yes, sir.
Management of ovarian mass, that you have said the cutoff is 4 cm, who are basically keen for reproduction.
Yeah.
I am asking about the unmarried girls. Sometimes we found there is an endometriotic cyst who are not going to get married very soon. In that case,
medical management is the key. We have to elevate her pain. So Dynogest we can keep for 2 years and more. Progesterone.
If there is an asymptomatic endometriosis, that is not significant pain. So what should be the management guidelines?
Sir, with Dynogest, the size of endometriotic cyst also reduces. So I think we should give treatment to them so that the cyst size does not increases. And if it increases, there are chances of this torsion, rupture, hemorrhage, and other complications.
Now, what is the cutoff that I'm asking? Who are not keen for reproduction? 4 cm again, or
4 cm.
I mean, though practically sometimes to 6 to 8 centimeter also we have left, given them Dynogest or other medication, because then if you do surgery, unmarried girls, that's also many patients don't want actually surgery. You will they will have a scar there, and it might, the parents are concerned about marriage of them. And quite often actually the Dynogest, they are good medication, and we have seen even 8 centimeter reducing to 6, then 4 or 5, or they are. And sadly, that even if you do endometriotic cystectomy, many times tends to come back also. And Dr. Ruchika, last question, like suppose patient, what is your, traditionally we have been taught, if once the family is complete and they are having recurrent endometriosis, that do THBS, so that is the ultimate cure and all. Do you agree with that? Patient is 36-year-old, 38-year-old, recurrent endometriosis is in agony, and then family complete, one baby only.
Sir, we should do, along with the excision of the lesions also, which we can see.
Yeah, I mean practically I have seen
and
it
post-operatively, we can put the patient on progesterone for long periods.
Absolutely.
So that there will be no recurrence.
So some patients I recently operated, she had one lap cystectomy in London, second in Germany, her husband was working there. Then she had one laparotomy in India, another, and ultimately she was having 42-year-old, no baby, but she adopted a child. She was having big fibroid, endometriosis, and left hydroureter nephrosis. And then, she was admitted, we had to give her 2 injections to take control of pain. So ultimately, I did laparotomy for her, did complete THBHO, called urologist and surgeon. Luckily, didn't have to, and now she's totally pain free. So sometimes practically you have to see individualize the patient. I think.
Yes.
So thank you, Dr. Ruchika, and we wish you all the best for your books. They're lovely. You have bright future, and we want to see in Foxy also.
Yes, sir.
Thank
Thank
you.
you, sir.
Okay, thank you very much. Thank you.